Good afternoon, wherever you are. Maybe some are still good morning over in the West. Firstly, I'd like to acknowledge the traditional owners of the lands where we meet today. And for me, that's the Kaurna people of the Adelaide Plains. And to pay my respects to their elders, past, present, and emerging, and to acknowledge any Aboriginal and Torres Strait Islander people who may be with us today. This is a very timely presentation today, considering it's Rail Safety Week. And there's a lot of good stuff that goes on in the background that in the industry we can quite easily take for granted. And one of those is the framework and the systems in place that we have in the industry to assure that any rail safety workers with health conditions have the monitoring and support they need to keep themselves and Australia's rail systems safe. Under our Rail Safety National Law, rail transport operators are required to manage the risks posed by the ill health of rail safety workers, and the National Standard for Health Assessment of Rail Safety Workers provides practical guidance for transport operators to meet those obligations. The NTC standard has been revised over the past almost 2 years and is in the final stages of approval. And the supporting systems that we have in place to govern the processes around health assessments has been further bolstered by the development of a new authorised health professional program. So we've got a couple of presenters today who are experts in their respective areas. Firstly, I'd like to introduce Josie Thomas. Josie's the Principal Policy Advisor at the National Transport Commission, and has worked on transport reform projects for over 7 years. Josie's the project manager for the review of the National Standard for Health Assessment of Rail Safety Workers and assessing fitness to drive. She's worked closely with key stakeholders over the past 2 years, including government, rail transport operators, medical specialists, unions, the Office of the National Rail Safety Regulator and industry to update and strengthen the standard. So Josie will speak first to give us an overview of where key changes to the standard and where we're at with it. And then after that, we'll hear from Griffin Smith, who's the Key Account Manager at Metro Trains Australia. He's the Project Manager for the Authorised Health Professionals Program, and again has worked closely with stakeholders, including NTC, RISB and medical specialists to deliver the AHP program. So without any further delay, I'd like to hand over and welcome Josie.
Thank you. Before we begin, I'd like to acknowledge that I'm presenting this webinar from the lands of the Yorta Yorta people. I acknowledge the traditional custodians of the various lands on which you all work today and the Aboriginal and Torres Strait Islander people participating in this session. I pay my respects to elders past, present and emerging. As Damien mentioned, my name is Josie Thomas and I'm a Project Manager at the National Transport Commission for the review of the Rail Medical Standard. Thanks Damien and the RISB team for inviting Griffin and I along today to provide you with an update on the review of the standard as well as the AHP program. These two projects both have strong links to rail safety and are both fundamental in assuring the health and fitness of all workers on the rail network. It's encouraging to see so many of you joining the webinar today to hear about these projects. And as we've got a mixed audience today with operators, workers and health professionals, I'll keep it high level and leave the detailed medical descriptions to the upcoming AHP training. I'll provide an overview of the changes being proposed under the standard and then hand over to my co-pilot Griffin to speak to the AHP program. Firstly, I'd like to note that the standard is currently with ministers and all the content I'll discuss today is still in a draft proposal form until we receive the final ministerial approval. For those of you who haven't been directly involved in the project, here's an overview of the review process to date. The review of the rail standard commenced in January 2022, and since then we've consulted extensively with stakeholders to identify and resolve issues with the 2017 edition. We engaged Project Health to assist with the review, and they've had involvement with the standard since it was first developed in 2004. As I just mentioned, the standard is currently with ministers, and we're expecting a decision in the next 6 weeks. We'll then publish the standard and begin our implementation work. We're proposing a 6-week implementation period for authorised health professionals, or AHPs, as I'll call them throughout the presentation, to be retrained, with the standard coming into effect in late October. From this date, all health assessments will need to be performed under the 2024 edition of the standard. In terms of consultation, we've undertaken a comprehensive set of activities, including the following. We've adopted a robust consultation process with advisory groups, information sessions, and individual meetings with stakeholders. From the beginning of the project, we established a rail health advisory group with members nominated from ONSA, RTBU, operators, government departments, and chief medical officers. These members reviewed and provided advice on the various issues and versions of the document. We discussed and resolved matters at the Rail Health Advisory Group and escalated to the Chief Medical Officers Council, or CMOC, and also had medical specialists in the fields of cardiovascular, diabetes, sleep, hearing, vision, and neurodevelopmental disorders. These specialist bodies have all endorsed their respective medical chapters in the standard. We've also worked closely with ONSA to discuss and resolve issues. We've had detailed input from the Australian Manufacturing Workers Union and the Rail, Tram and Bus Union. We ran information sessions on the changes to operators, including sessions for large operators and for the tourist and heritage sector. We've also received feedback that the rail standard is considered best practice in the transport medical space, and we provided advice to the UK RSSB team on their rail medical standard, as well as maritime pilots in Australia. In terms of implementation, we've been working really closely with RSB and the AHP Program on a communication and education plan. To successfully support the introduction and transition to the new standard, we've prepared a set of resources that include a consultation report and summary of changes, which will make it easy to refer to and understand what's changed, 2 fact sheets, one for workers and one for operators, and these will be available on the NTC website when the standard is published. We've also produced a stakeholder information kit, and this will have information for different audiences to be able to pick up and use in their communications to their members to advise what's changed in the standard. We've identified a variety of channels and opportunities to get the message out when the standard is released, so you'll definitely know when it's out. We're also working with RSB to develop 2 training options for new and existing AHPs. RSB will provide some further information to AHPs on this. I'll start by going through the changes proposed in the medical chapters and then focus on the administrative aspects. I'll keep this high level as the detail is of most interest to the AHPs who'll receive detailed training on this. So based on the feedback received during the consultation period, we've made changes to the following chapters: cardiovascular conditions, diabetes, hearing, neurodevelopmental disorders, musculoskeletal conditions, sleep disorders, and vision. We've not made substantial changes to the chapters relating to blackouts, neurological conditions, psychiatric conditions, substance misuse, and dependence. In the cardiovascular conditions chapter, the requirement for fasting pathology has been removed. The chapter now includes the new version of the Australian Cardiovascular Risk Calculator, which is applied to Category 1 workers. The new CVD risk calculator is specific to Australia and takes into consideration more information than the previous version, which was published in 2012. It's considered more accurate, with an improved ability to identify people at risk of cardiovascular events in the next 5 years. This won't be applied to workers under 30 years of age. Workers who are assessed as being at high risk of a cardiovascular event will be referred for an assessment by a cardiologist. Routine exercise stress tests will only be conducted on the advice of the treating cardiologist. This will reduce the testing burden for all parties and is consistent with clinical best practice. The review periods for Category 1 workers with cardiovascular disease will now be annually, which is in line with other standards. In the diabetes chapter, similar to cardiac, workers won't need to fast for their pathology testing. Category 2 workers will now be screened for diabetes via a urine glucose test, which also does not require fasting. Up until now, diabetes in Category 2 workers has been identified by self-report, while Category 1 workers underwent screening via a blood test. This means that diabetes may have been missed due to lack of screening in Category 2 workers. Category 1 and 2 workers with diabetes that is satisfactorily controlled may be able to be reviewed by their GP or AHP rather than going back to their specialist. This change should reduce the need for unnecessary specialist appointments just for a letter. Despite the consultation draft featuring a reduced hearing threshold of 35 decibels, the threshold will remain at 40 decibels due to stakeholder feedback and lack of evidence of impact of hearing loss in rail safety. Workers presenting with self-reported hearing loss and any incidents or workplace reports of communication difficulties will be assessed more fully. All workers with hearing loss greater than 20 decibels will also be referred to the operator's hearing conservation program to facilitate further prevention of hearing loss. Stakeholder feedback during consultation pointed to concerns regarding assessments regarding musculoskeletal requirements. Examples were given where workers were being assessed as fit for duty when they were off with an injury. Workers felt that they were being assessed at levels that were not consistent with roles, and was demonstrating in excess of those required for the role. A working group was established with representation from operators, health professionals, and the union. It was determined that the chapter itself set out the requirements for the assessment accurately, but the gap appears to be in implementation, with health professionals not tailoring the assessment to meet the task requirements. It was concluded that this could be addressed through AHP education, but also that operators proactively communicate the musculoskeletal requirements of the role so the assessment can be tailored accordingly. Changes have been made to the request and report form, the record for health professionals, and the health risk assessment template, which now provides space for the operator to record the musculoskeletal requirements. This is a new chapter, and it's been specifically developed to address neurodevelopmental disorders such as autism spectrum disorder and ADHD, which were not well covered by the other neurological disorders content in the standard. The new content has been well received as it provides detailed guidance around the potential and variable impacts on rail safety. During consultation, the College of Psychiatrists recommended inclusion of intellectual disability in this chapter. This is referred to in the text, but specific criteria are not included. It was noted that criteria for intellectual disability had been removed from an earlier edition of the standard, as it was less likely to present as a medical issue given the general competency requirements for rail safety work. There is also now mentioned in the prescribed drugs section that while stimulant medications prescribed to treat ADHD are unlikely to result in impairment unless there's abuse, they are likely to be detected in a random drug test, and rail safety workers should be advised accordingly. The sleep chapter was generally well accepted by stakeholders, acknowledging that in the inclusion of improved screening processes, such as the stop bang, this would likely result in more workers being referred for sleep studies and being treated for sleep apnea. Published evidence from New South Wales on the impact of sleep disorders has further enhanced the rationale for the assessment and management approach. Following the public consultation period, there's been ongoing input from the Australasian Sleep Association and CMOG to refine various aspects of the assessment and management to support consistency and facilitate management of workers with sleep apnea. This included the stratification of workers based on their sleep study results, either being fit subject to review or temporarily unfit for duty, guidance regarding management of increased risk factors, and more detailed guidance about the application of the maintenance of wakefulness test. Definitions of obstructive sleep apnea and obstructive sleep apnea syndrome were also clarified to support differential management of risk. A pro forma has been included to support understanding of the role of workplace reports in identifying potential sleep disorders, which ensures fairness. We've also been conscious to address the burden of attending sleep specialist appointments. In some cases, the AHP may undertake the review for workers if there's an established pattern of compliance and successful treatment. More in-depth training for AHPs will equip them to do this. The vision chapter has been updated to state that workers with stable vision conditions will be categorised as fit for duty unconditional if they meet the visual acuity and visual fields criteria. Workers with progressive vision conditions who currently meet the fitness for duty criteria will be fit for duty subject to review to enable monitoring of the progression of their condition. There's been some refinement of the visual acuity section, which includes removing the flowchart, which had become difficult to interpret. Content has also been added to address laser surgery and includes consideration of non-working periods and refers to potential effects, including sensitivity to glare, starbursts, and double vision that might affect fitness for duty in the short term. In more recent months, while we're giving consideration to the authorisation of health professionals, it became evident that AHPs conducting Category 3 assessments would be called upon to make assessments in relation to medical conditions declared by the worker, such as epilepsy, cardiovascular disease, and diabetes, in line with the formal incorporation of the RISB technical note. Given that these AHPs are not required to be medically trained, consideration was given to the implications for fitness for duty reports. The standard now requires that these non-medically trained AHPs conduct the assessment under the supervision of medically trained AHPs. This is to enable the appropriate management and of these particular medical conditions, as I mentioned, epilepsy, cardiovascular disease, and diabetes, which are managed for Cat 1 and 2 workers. They are not able to sign off on fitness for duty of workers with these medical conditions. During the review, we received feedback from stakeholders as well as data that indicated issues with quality and consistency of AHP decisions. Feedback has suggested that many non-AHPs are conducting assessments which are either being signed off by a single AHP or being signed off by a GP. That is not the intent of the standard, so we hope that these changes, along with the new AHP program, prevent these issues from reoccurring. The standard now clearly states that only AHPs authorised according to the standard may conduct health assessments. We've included an explicit exemption to this requirement where a lack of access to an AHP, such as the worker being in a remote location, may prevent them from having their medical on time. The CMO will need to sign off on the fit slip, and this will be recorded and monitored via the AHP program to ensure that it does not become common practice to allow non-AHPs to perform assessments regularly. This information will be shared with the NTC and allow us to monitor implementation of the standard between formal reviews. We've also included content to state authorisation is only through the AHP program being led by RISB, and that AHPs must pass training and be registered, and Griffin will speak to this in more detail shortly. Part 2 has been updated to include a power for the CMO, with the support of the operator, to extend a worker's medical expiry by 1 month. This should be limited to exceptional circumstances, including not having a medical report in time or the worker being off sick at the time when the medical is due to expire. We hope that this provides some flexibility to prevent workers being stood down with an expired medical. Part 2 has also been updated to include a minimum notice period of 10 working days for periodic and non-urgent triggered health assessments, such as fit for duty subject to review assessments, unless varied via mutual agreement between the operator and worker. The current standard requires operators to establish systems for managing health assessments and to ensure adequate notice be provided. However, stakeholders have suggested that this isn't always the case and it needs to be further strengthened in the standard. Stakeholders sought clarification, including guidance on prescribed drugs, including medicinal marijuana. New content has been added in Part 3 regarding the Rail Safety National Law, prohibiting a worker carrying out work with alcohol or a prescribed drug in their system. The standard now lists the 3 drugs that are defined in the Rail Safety National Law to remove any doubt. Until there's a change in the law, supported by strong evidence, the standard can't allow for workers to be carrying out rail safety work, even if they have a valid prescription for a prescribed drug. There have been changes to the forms to promote usability, address where common errors have been made, and to bring together the strongest elements of the several iterations of the model forms out there. The suite of forms will improve the health assessment process and support quality and consistency, and the model forms should be used by all operators where possible. I've included the request and report form on the screen, although it's a little bit hard to read. It shows the 4 pages, including the last page, which is the new fit slip. The finalisation of these forms has involved extensive consultation with CMOs, RIW program, operators and unions. We've also prepared some guidance notes, which will be in Appendix A in the summary of changes to understand what's changed in the forms. And as I mentioned earlier, during the review, we heard from stakeholders around the concerns they're faced around quality and consistency of health assessment outcomes by AHPs and non-AHPs. There's currently no expiry date for AHPs to be removed from the list or refresher training to keep AHPs up to date with these relevant changes. The new AHP program seeks to address these issues. We've worked closely with RISB and MTA to design the program, and I'll now hand over to Griffin to talk you through the details.
Good afternoon all. My name is Griffin Smith and I'm the Project Manager for the Authorised Health Professional Program. I've been working closely with RISB, NTC and the Chief Medical Officers to develop and implement the new AHP program. I'd like to thank RISB for the opportunity to speak at this informative webinar. With the National Standard for Health Assessments of Rail Safety Workers nearing publication, NTC and RISB and the CMOC have taken the opportunity to improve the quality, governance and assurance of the AHP program. The current AHP list faces a number of administrative challenges, and the new AHP program aims to resolve these issues while enhancing the functionality required to keep the list of AHPs up to date. To name a few of the risks and issues the current AHP list faces, currently, once the AHP training is completed with the Chief Medical Officer, there is no expiry date for the accreditation. There is no governance of the list to ensure AHP's validity and that they have been trained according to the most recent national standard by a Chief Medical Officer. There is no standard communication framework with AHPs from NTC, RISB and CMOC. There is no refresher training or assessments to keep AHPs up to date with the relevant changes year on year. There is no assurance for network operators or principal contractors. AHPs that move or change practices do not or are unable to find the process to update their clinic details, which causes confusion to industry. So next slide, please. Metro Trains Australia and RISB have collaborated to develop the new AHP program, ensuring a professional and comprehensive end-to-end administration process. The new AHP program will act as a central hub for Australian Chief Medical Officers and AHPs and rail network operators to efficiently manage the scheduling of training with AHPs, as well as identifying certified AHPs to conduct medical assessments for rail workers. The new AHP program is scheduled to be operational from September 2024 and will provide a low maintenance, easily accessible and up-to-date directory for participating AHPs. To be able to conduct medical assessments for rail workers under the new standard, AHPs will need to carry out mandatory training and register with the AHP program. Further information on the new program and the steps that AHPs need to take will be communicated shortly. A few key benefits of the AHP program. The AHP program will facilitate the delivery of training to existing AHPs to ensure their readiness to deliver health assessments in line with the 2024 standard. It will be provided a new online portal to manage all aspects of the AHP program, including training, registration, and re-accreditation of AHPs annually. It will provide access to relevant AHP-only resources. The AHP directory will be governed by CMOC, RISB, and NTC, and operated by MTA. It will provide rail transport operators and rail safety workers with an easily accessible and up-to-date list of AHPs. The improved functionality of the new AHP program will enable AHPs to locate chief medical officers, training dates, and details and contacts to book in a session. It will allow AHPs to complete online assessments once they have completed the training with the chief medical officer. AHPs will be able to manage their own data in the portal and update their clinic information live to the AHP directory. AHPs will have access to AHP-only resources, ability to pay their annual membership fee, receive notifications and subscription and reaccreditation expiry notifications, complete an online reaccreditation assessment on an annual basis through the AHP portal. The process to become or remain accredited as an AHP is changing. More detailed information on how to become an AHP and stay accredited will be sent to the current AHPs and will also be published on the new AHP program website, scheduled to be launched in the coming weeks. The below flowchart walks through the process of joining the AHP program. Training dates with chief medical officers will be published on the AHP program's website. A medical practitioner books in a session with a chief medical officer. These training dates will be available in the coming weeks. Training will be conducted over a 6-week period in September and October prior to the standard going live. Once the session is completed with the chief medical officer, the details of the AHP is provided to the AHP program to access the portal. The AHP will receive an onboarding email with the login details to access the portal. And once in the portal, AHPs will have access to pay their yearly subscription fee. This fee will be $275, including GST. Next, complete the online e-learning assessment. And once the e-learning assessment is completed, AHPs will have access to update their clinic details, which will be published on the AHP directory, which will be used by rail workers, network operators, and the wider rail industry to search with a geolocation map for approved AHPs to conduct rail medicals as per the national standard. AHPs will gain access to resources, news, yearly reaccreditation assessments, updates from NTC, RISB, and CMOC with a direct line of communication. Lastly, just to highlight a few details from our presentation. The website is looking to be launched in August 2024. Training sessions with chief medical officers will be available from September to October to complete the sessions. Portal access for AHPs will be granted upon completion of the training with chief medical officers. Accreditation requirements that all AHPs must be trained and have portal access by the end of October, in line with the national standard going live. Rail medicals cannot be conducted by medical practitioners not accredited by the AHP program. And finally, the cost of the AHP program is also $275, including GST. Please look out for further communication from RISB in the coming weeks. If you have any further questions post this webinar, please reach out to us at contact@ahpprograms.com.au.
Thank you, Josie and Griffin. Well done. Here, we've got one question here. I would like to know if the new Queensland Work Health and Safety Auditory 2-yearly reassessment will be integrated. I guess that's a question for you, Josie, and does reflect the challenge we have in the rail industry of either the opportunity or challenge of integrating work health and safety and rail safety requirements.
Yeah, that's a good question. So we received feedback from Audiology Australia. They didn't specifically raise that change for the Queensland context, but it's something that we can take offline and consider in more detail. Obviously, for the current standard, it's before ministers at this stage, but we are also compiling a list of issues to carry over to the next standard. So if it's something that can't be dealt with through sort of Queensland policy, I'll definitely add it to the list for the next review.
Okay, thank you. And I was about to say the questions are coming through thick and fast now. Both your presentations create a picture of smooth sailing in the development of both the programs, which we would expect at a presentation. Do you want to share any of the challenges that you each might have had through this process?
Yeah, the rail standard has obviously faced a few stakeholder consultation challenges, but I feel that we're able to sort of use them to our advantage to give us a little bit more time to explore, details that didn't come to light in the early stages of our, issues paper and public consultation period. So I feel that, yeah, the standard is much stronger and improved. And we've also had a little bit more time to focus on implementation, which has given us, the time to really focus on fact sheets for workers and operators that will be really beneficial during the transition period. And yeah, allowed us to work quite closely with MTA and RISB, which has been wonderful as well.
Right. And Griffin, any challenges you want to share?
Yeah, I think this project began over 2 years ago with consultation, obviously, with RISB and NTC, and just working with a variety of stakeholders and network operators, doctors, chief medical officers, just to get the right process down pat. And I think we're at that end line now, that finish line, where after a lot of feedback, we've fine-tuned everything and got the program almost ready to go for next month's launch.
Right, thanks. Just a couple of questions. Well, firstly, great presentation. In relation to the sleep disorders summary of key changes, can you elaborate more on how the published evidence on the impact of sleep disorders enhanced the rationale for assessment and management? And how important was this for the rationale? I don't think this is a trick question.
Yeah, so between the 2017 edition and us undertaking this review, there was an excellent piece of research undertaken in New South Wales that found that there was a really high rate of undiagnosed sleep disorders in rail safety workers. And that sort of critical piece of information was missing from earlier editions, so we weren't able to make any changes until we had the evidence before us. So we're able to use that as sort of the consultation piece last year, and also use that to inform discussions with the Office of Best Practice Regulation. So they were satisfied that that provided us with the level of evidence we needed to make such a change. We also worked really closely with the Australasian Sleep Association and also the University of Toronto, who developed the Stop Bang questionnaire. So they've also reviewed how we've incorporated that into our sort of screening process and description in the standard chapter itself.
Great, thank you. Is there an annual registration fee hereafter? So I assume they're questioning whether there's an annual fee. Yes, there is, and any of the parties aren't making much money out of it. As Griffin said, it's $275. So we've kept that the minimum amount that we can, but also making sure there's sufficient resource to continue to maintain, support, and update the systems. So I think we've got a reasonable outcome there. Why would rural and remote GPs bother to become AHPs? Look, it's a very good question and is a key risk. Obviously, we currently already do. The industry does rely on rural or remote GPs because many of the rail industry does work in those locations. So it is a keen issue to make sure that it's worthwhile for people. And part of that is, as I said, a pretty low registration fee in our view. But it is a key risk that the industry's keeping an eye on to make sure that there are sufficient AHPs in the industry in remote locations. Great presentation. Are there phase-in out considerations for the new standard. What happens if a current fit employee is considered unfit under the new standard? Or is the expectation that operators manage this in accordance with their current unfit for work processes?
Yeah, that's correct. So once the new standard commences in October, late October, if a worker undergoes a health assessment and they have a different outcome to what they may have had under the 2017 standard, they'll need to follow the guidance for that particular category. It is possible that that might be the case in, potentially under the sleep chapter, but that's why we've tried to, incorporate AHPs being able to review and look at the compliance for sleep apnea, CPAP, just to, prevent, workers being unnecessarily stood down for a long period of time if they can't, for example, get into their specialist. But we're hoping that that's not going to cause a huge burden on operators. Based on the statistics that we were provided through our consultation, it should be a smaller number.
Great, thanks, Josie. We've got a note here that we've got an incorrect details for a doctor, so we'll sort that out. Thank you for letting us know. One other down here, and I probably should know the answer to this. I understand, so this is from a doctor, if we have previously completed AHP refresher training last year, do not attend further face-to-face training prior to October 24, but complete the online training. Is this correct? Not sure if either of you guys have got the answer to that. If not, I know there's a CMOC, Chief Medical Officers Council meeting this week in Brisbane that would be finalising the position on those things.
Yeah, that's correct. So once the decision has been made around the planning for the training, some communication will be released to all AHPs, particularly around dates, so people can start getting things booked in their calendars for September and October.
No worries. And I think, could you please confirm the slides will be sent out? Yes, we'll make sure that they're available to people who've registered. I think we'll bring it to a close there. Look, thank you so much, Josie and Griffin, on, I know, what has been an enormous amount of work. As I said at the outset, this is something that we in the industry take for granted. We have extremely good standards to assure the health of people operating in a rail safety environment. I think the latest revision has just further bolstered that, and likewise further supported by a new system to help further assure the compliance requirements of authorised health professionals. And just lastly, our next webinar will be on the 20th of August, improving the safety of train compartments in Korea. So this is obviously an international presenter that's talking about the safety of the passenger rail operations in Korea. So I think that'll be another great presentation to listen in to look into. Thank you again for everyone who's attended. We'll get back to all the questions that are there, and enjoy the rest of your day. Thank you.
Thanks, Damien.
Thanks, Damien. Thanks, everyone.